So just a little background about myself. Most of you know who I am, but my name is Jerry Leong. I'm with a company called Healthcare Coding Consultants of Hawaii. And we are a Honolulu-based company, and we provide coding support for providers, physicians and hospitals and clinics and whatnot. By coding support, we have clients that we do all of their coding for them. They don't have coders on staff, so we do concurrent coding before they send out their bills. We have a lot of clients that we do back-end auditing type stuff where they've sent their bills out, but they just want to do a checkup on themselves and make sure things were correct. So my goal for today is to introduce you to ICD-10, show you what it looks like, how it's different from ICD-9. So whatever you're doing now with ICD-9 within the organization, and obviously everyone touches it in a little different way, whether it's the nurses or the claims folks or anybody who's doing pre-certs, authorizations, physician or provider outreach, everybody touches it a little bit differently, but I'll cover the basics and how that's different and how it will change. Because the perception is that ICD-10 is just a coding change, and it is, but it's really going to affect every single aspect of your business process within Aloha Care. I'm going to try to engage the organization for the transition. So I want to get you on board. I want to get you saying, okay, great, I'm excited about ICD-10 instead of, oh no, gloom and doom, how are we going to do this? So that's going to be my second task. And then we'll talk about some tools that will be helpful as you migrate through this transition. You've probably got a lot of these tools built into the programs and the software that you use already. But what about, say, a nurse who's sitting there and doing a pre-authorization on a particular procedure? How will she do a quick lookup? So we've got some solutions for that as well that I can show you, or what you might be looking for when you talk to your vendors. So when we talk about ICD-10, we really consider it to be happening in 5 phases. Almost everybody, clinics, hospitals, everybody, no matter how sophisticated they are or no matter how large the organization is, it's kind of surprising to me, but almost everybody is still in phase 1. And phase 1 is really what we're doing right now. It's just educating and engaging the practices or yourselves, the health plans. It's really just educating everybody, introducing them to what it is, what ICD-10 is, and how it will change your business processes. We talk about assessing the current readiness and impact on the hospital or the clinic or the practice. And this is a big one because, you know, I probably do one of these types of presentations, maybe every couple times a week. I've been doing something like this for various organizations, and I always say to the practices or the FQHCs, the health centers, so what have you done? How many of you started on ICD-10? And there'll be, 100 people and there's one hand. And so it's kind of amazing to me that folks are still scratching their heads trying to figure out how to do this. So your providers, the community health centers, the FQHCs, the hospitals really aren't as far along in this transition as I would hope that they would be at this point. But we're getting there, and we can only do what we can do. But one of the things we recommend to the health centers is to go out, is to internally start doing this impact assessment, find out, where are they, what do they need to do, where to start. Creating a timeline, even for Aloha Care, creating a timeline that, okay, January 27th, Jerry's going to come and give us this awareness thing. February 28th, we're going to do this. March 15th, we'll do this. April 30th, by that date, we will be doing this. By, March 31st, we will be accepting test claims from providers. You're already getting questions about that, I'm sure, because I hear that in the community as to when can we start? When can we send you a pretend file with ICD-10? So creating a timeline within the organization would be coming up with what we expect to be doing by these certain dates. Now you can always twiddle with those dates. It doesn't have to be hard and fast, but having some kind of a timeline and transition plan, so at least you've got those goals to meet. It's going to change a lot. It'll be a lot of moving parts between now and October 1st. Sooner or later, once you create this, you've got to implement that transition plan. So you have to really be able to say, we decided we were going to be doing this on March 1st and this on April 15th and this on July 1st, and really then follow through with that. Post-transition, phase 5 of the ICD-10. Phase 5, there's nothing we can do about that right now except to anticipate the increased needs. We really have 8 months left before October 1st, right? If we start thinking in terms of February 1st, going forward, we've got 8 months to get this all figured out and be prepared, and not just prepared physically with the software in place, but anticipating additional needs. So, 9 months from now, those batches of claims have come in, and you're processing those, and we'll talk about a lot of the different moving parts with that. But now you're looking at increased needs for customer service. Those providers are going to be calling you up and saying, I sent you my claims, I haven't gotten paid, what's going on? Or they're getting rejections because their ICD-10 coding wasn't correct. They're getting rejections because they mapped their ICD-9 code to a 10 code that really wasn't a correct map. And we'll talk a lot about that in a few minutes. But looking at, preparing yourselves for increased needs. It isn't even post-transition, because all of those authorizations that are coming in now for 2014 with ICD-9 codes, those will have to be transitioned to ICD-10 codes, correct? Because if you, let's say long-term care, if you authorize a year's worth of long-term care, ICD-9, come, I don't know, June, July, August, September, somewhere around there, those authorizations all have to be redone with an ICD-10 code. So when that claim comes in with a 10 code, it gets processed smoothly. Or it comes in with a 10 code that gets backwards mapped to an ICD-9 code internally. Those are decisions that need to be talked about, and maybe you've already decided this, how you're going to process those claims. And we'll talk more, and I'll explain what that frontwards mapping and backwards mapping is all about. I'll explain that a little bit more. But just know that you've got to anticipate a lot of this stuff, and now's a good time to do it, because whether you're increasing your staffing to cover the demands, whether you've got part-timers that come in and help with redoing some of those authorizations, if you're going to internally map those ICD-9 authorization codes to a 10, who's going to do that? Even if you've got a system, a product to do it, somebody physically still has to do it. So it's just thinking ahead to some of the increased needs and demands over the next several months. Okay, so a little bit of background about ICD, both 9 and 10, the International Classification of Diseases, or ICD. Both 9 and 10 evolved from earlier versions. It goes all the way back to ICD-1, way back in around 1900 or thereabouts. But originally, the International Classification of Diseases was really to sort of track causes of death. So how many people died from smallpox and bubonic plague and stuff like that. It really wasn't used by third-party payers to track disease process, chronic conditions, comorbidities, that sort of thing. The first ICD code set that was required for billing purposes was somewhere, and there's a few of us in this room, a couple of us that have been around that long to remember that prior to 1989 or 1990, we didn't have to use numbers for diagnosis codes. We just wrote it out on a claim form. We submitted a claim form and we said fractured wrist, sent it in with that written description, and we got paid for that. We didn't have to do numbers. In 1989, the World Health Organization said, okay, we're done with all this written stuff. Now we're going to have numbers that will be attached to each one of those diagnosis descriptions. And so we started using it for billing purposes in 1990. Doesn't seem like it was that long ago, but prior to that, we were using just handwritten descriptions for payment. As far as ICD-10 goes, the United States is the last industrialized nation to implement ICD-10. That's an oddity to me, because the US always wants to be first with things that we do, but they weren't and aren't with ICD-10. There are a whole lot of countries that are using ICD-10 and have been for a long time. Canada and Australia and Germany and New Zealand, and some of them have been using it for 10 years. So part of the reason that we're switching is because there's no consistency in data capture worldwide, right? So if we're looking at H1N1 flu in Germany versus United States, there's no way to compare worldwide information because we're still stuck in the muck using ICD-9s where everyone else has been reporting it for some time now with ICD-10 codes. So World Health Organization was kind of behind it. Centers for Medicare and Medicaid Services has been proactive with that. The American Medical Association, the AMA, the physician organization has been fighting and kicking and screaming about ICD-10 forever, and continues to do so even now, wanting it delayed and more delayed. But CMS has basically said, we are so done with delays. It's going to happen this year. It will be effective October 1st, not going back. So even the AMA is now conducting ICD-10 training classes. So that tells me that even though they're saying we don't want to do it, they're getting on board. And that's a big favor that the AMA can do for the physicians, because as you know, the delay has kind of hurt us with readiness, because there are still folks saying, oh, it's not going to happen, it isn't going to happen. There's less and less of those people, the negative ones out there now, but there's still a few. So ICD-9 is old, it's outdated. There's only so many 4th and 5th digits to go around, so a lot of the categories within ICD-9 are maxed out. There's no more 5th digits to add to it. So it's really just add capacity. And really, ICD-9 is just not descriptive enough to really, for a lot of different diagnostic categories. And you know, or your providers will tell you, will attest to it as well, that they're looking for a diagnosis code, trying to find it, there just isn't one that fully or accurately describes what they did or what the patient has. And so really it's just not descriptive enough, and so we won't have that problem with ICD-10. I'll show you why in just a moment. 2 parts. You folks will be dealing with both parts. ICD-10 PCS is the procedure coding system. It is the equivalent of what you know now as ICD-9 Volume 3. So for the hospitals that report inpatient procedures, they don't use CPT codes. They use Volume 3 ICD procedure codes. So this is replacing it. There is no book for ICD-10 PCS. There is no lookup. It's not like you can open a book and find an appendectomy. All of these codes are now built. So the ICD-10 PCS book is sections. Was it medical or surgical section? What system of the body is involved? What procedure was performed? What approach? Was it open versus laparoscopic? So every single one of these surgical procedures is built. So from a productivity perspective, hospital coders are going to be way slowed down, right? Because now they open up the book, they find laparoscopic appendectomy, bingo, they're done. Now every one of these codes will be built based on 7 categories within that code, and it's built. Surgical system, GI system, laparoscopic approach, mesh was involved, you're going to build it. It's sort of like build your burger, and that's what you're doing with ICD-10 PCS. CM, ICD-10 CM is what will be used on the outpatient side. This is the diagnostic version. These are procedures. ICD-10 clinical modification is the diagnostic coding book or file, data file. And this is what folks will use for all their outpatient claims, as well as anything that's not an inpatient surgical procedure. Everyone will use this. So now the coders will struggle because they're learning this. An inpatient hospital coder will now be learning this new and learning this new. So just from a productivity perspective, you're going to see probably a slowdown in the claim submission. You'll see inaccuracy in those claim submission. You'll have a slowdown on your end when you're reviewing it. Because if someone manually reviews one of these surgeries, they're going to have to unbuild it, right? Rebuild it based on how did the coder in the hospital get that code. Okay, here's the thing. We're going from about 14,000 ICD-9 codes to just under, this is up a little bit, it's just under 70,000 ICD-10 codes. So this is usually the place where the providers look at this and just go, okay, I give up. 14,000, 69,000, I'm never going to learn it. It's not like the patients have any more new diseases, right? They're still going to be treating their same patients for the same disease conditions. We haven't invented any new diseases. All that's been invented is a more specific way to report it. So the doctors will still be treating what they were treating. but how they're going to report it, how they will document it and report it will be different and much increased. Implementation date is October 1st, 2014. On the outpatient side, this date is firm, so if a patient is in the hospital from September 29th through October 2nd, that provider will send you 2 bills. One with ICD-9s up through midnight September 30th, and another with ICD-10 starting October 1. For the hospital coders, it's based on date of discharge. So September 29th to October 2nd, they will bill you only ICD-10 because it's based on the date that patient went home. Okay, so how do we get started? How do we begin to understand ICD-10 and how it's going to affect us, all of us? We'll talk about the differences between the 2 code systems. We'll talk about a mapping system. I'm going to show you how that works. A mapping system to pretty much identify as well as help the physicians understand what they need to document, what the increased documentation demands are. 14,000 to 69,000, right? So you know that anything on your body that you have 2 of, eyeballs, ears, knees, breasts, anything you have 2 of, used to have 1 code, right? Breast abscess, and now you'll have at least 2 and maybe 3, left, right, bilateral. So that's where some of the increase comes in. Along with that comes the increased documentation demands. You're going to get a claim for left breast abscess. You request notes or you do post-payment review, and that clinical impression says breast abscess. That's unspecified. You've already got a mismatch, right? They billed you left, they documented unspecified. So what we're doing in the community right now is not teaching the codes, or we're trying not to teach codes because it's still a little too soon, but we're teaching those increased documentation demands. That if you're going to bill a left eye conjunctivitis, your note better say that. And the doctors will say, well, it's up in my exam, it says the left eye was inflamed. Okay, but in your final impression and plan, did it say left? Because if it didn't, and that's where your billing is pulling from, you're going to have that mismatch. So we'll talk about the increased documentation demands. Those documentation requirements, everybody, the perception right now, and I hear this 5 times every single day probably from providers, is I'm not even worried about it. My EMR is going to take care of everything. I've got a really good electronic health record, and just like now, it gives me a drop-down list, and I pick from that list. It's going to give me a drop-down list in ICD-10, and I'm sure it will. But right now, that list that's this big is now going to be this big. Are they going to scroll all the way down and pick the one that they need? My guess is they're going to be so happy that they found it in the first place, they'll pick the first one that comes up on the list. And in some sections, unspecified is that first code. Whereas typically now with ICD-9, they end in point 9. So most of the time they're last on that drop-down list. Won't be the case in ICD-10. Oddly, sometimes unspecified comes up and then right, left, bilateral. Go figure. Anyway, so we'll talk about, and then, eventually I'd like to talk a little bit about the benefits, but I don't really need to sell you guys on that because you already know that the benefits of the increased data that you obtain for CMS requirements as well as just internal requirements, just being able to capture left, right, bilateral will, along with a lot of other different criteria for the specificity, the increased information that you'll have at your fingertips will be helpful, will be very useful in knowing, the severity of illness, the extent of the illness, and so on and so forth. So there's a lot of opportunities. Okay, so in a nutshell, here's kind of what it looks like. ICD-9, somewhere between 3 and 5 numeric digits in length. So you might have a 3-digit code, you might have with a 4th digit or a 5th digit added to it. ICD-10, 3 to 7 alphanumeric characters in length. So we're increasing from 5. Not every code has 7, but a lot of them have 7. A bunch have 6, a lot have 5. So, but it's somewhere, so just the sheer size of what you're going to be receiving from a claims perspective will be increased. In ICD-9, you have 2 sections that are alphanumeric, but only 2, your V codes and your E codes, circumstances as well as accidents. So you only have 2 alphanumeric. In ICD-10, everything is alphanumeric. Character 1 will always be alpha, character 2 is numeric, and then anything after that, 3 to 7, it's anybody's ball game. So you're going to have a mishmash of looking codes. Lacks detail, very specific. In ICD-9, we do not care about laterality. We don't care if it's a left breast abscess. In ICD-10, we do. Not every section has laterality. I'm going to talk about that in just a moment. But many of the sections do have and require laterality as part of the code. And again, the numbers. So here's a little snapshot of the increase, what we anticipate for the increase for some specialties. I didn't go on and list all the other specialties because, as you can see, it got worse. So I didn't want to be like at 1,000% down here and discourage anybody. But if you look at infectious disease, for instance, they're not looking at a real huge increase in the volume of their codes. And why is that? Because right now in infectious disease, they'll code not only the condition, but the organism. So they're already more specific than a lot of other folks are having to document and code for their specialty. So if they have a strep pneumonia, they may already have a code that's strep pneumonia, and if they don't, they have pneumonia due to Streptococcus B. So they're already being more specific. So they won't see a huge change. Gastroenterology, only about 50% increase in their codes. Mental health, about 90%. A lot of this has to do with behavioral health codes have been quite specific for some time. So if it was bipolar or depression or whatever, we were already talking about a single episode or multiple episodes and how severe it was. But most of this is because now substance abuse is drilled down to the type of substance. And I mean really drilled down to, amphetamines versus, whatever other type of substance it may be. So we're seeing a lot of this. They use the codes in the same way, there's just a lot more of them. Cardiology, big increase for cardiology. Part of the reason there is that a number of the codes are now becoming much more specific as to other manifestations. So cardiovascular disease with acute angina something or other. There's now maybe additional codes as opposed to just cardiovascular disease. So there's a lot of combinations there that have been added. Myocardial infarction. The acute MI or heart attack codes currently in ICD-9, it's coded based on the general area of the heart where that infarction or obstruction took place. So the anterior wall or the posterior wall, that sort of thing. Now in ICD-10, it's specific to the vessel. So whether it's the circumflex or the left anterior descending or the main coronary artery, now they're coding it. It will be coded based on the exact location of that obstruction and that infarct. As a result of something like this, the coders are now going back to school because most coders are not clinical folks. Most coders are clerical folks that have learned coding, but they come up short on the anatomy side. So they need to know that a circumflex is different from an LAD, which is different from a main RCA, something like that. So the coders are going, eek, I need to go back and learn some of this stuff in order to be able to code it properly. So it's going to be a learning curve all around. Dermatology. Remember when I said anything you have 2 of, even some things you have 1 of, like your head, basal cell carcinoma left temple, basal cell carcinoma right cheek, squamous cell carcinoma left shoulder. So this is a huge increase, but a lot of it just has to do with the specific locations and the laterality. And I go to a dermatologist myself, and I get grilled on ICD-10 when I go in for an appointment. And but in his electronic health record, he said, I've had this program for quite a while now, and when I go in and I check, there's a diagram of the face. And he says, I click here, and I click here, and I click here, and I click here, and it auto-populates into his impression and plan. Left temple, right earlobe, left chin. And I said, wow, that is really cool, because that's half of the battle for him is not having to rewrite it because his software. Now, why a cardiologist couldn't have a picture of the heart in an illustration or something of the heart in their EMR and do this? I mean, if I was a software genius, that's probably what I'd be looking at doing, because that's going to help a lot. If there's some way that they can capture it and it populates into their impression of plan, they've got half that battle won. So this is not a happy slide when I speak to physicians. The only thing that is happy is that there's not orthopedics on here, because theirs is like 1,000%. So I didn't include it, and I just, try to downplay that. All right, so here's the differences. Here's what it looks like in ICD-9 and ICD-10. The good news is the process that you will follow in reviewing those diagnosis codes, if you do, the process you follow, the process that's followed by the providers is the same. ICD-9, there is a basic category. So let's say diabetes, 250. Fourth digit and fifth digit are added based on type 1, type 2, and other manifestations. Do they have other eye problems or kidney problems or something like that? And is it controlled or uncontrolled diabetes? So same idea, category, add some other information, which is manifestations and etiology and so forth. Same deal in ICD-10, there's a 3-character base category, and you add. The only difference is you might add more, but it's the same idea. Etiology, anatomic site, severity, these 3 characters, and we're going to talk about this extension code in just a moment. So here's what it looks like. Unspecified epilepsy, intractable without status epilepticus. In ICD-9, it looks like that. Here's your base code with something added. And in ICD-10, here's your base code with something added. This one's very similar. A lot of them, there's no connection. You'll try to make sense of it and just don't even try to make sense of it. Yes?
Jerry, you said it ranges from 3 to 7, so could you end up with just as an example here, the G40, and then there would be no characters after that? You might. There are some
3-character codes that still exist. Just like there are in ICD-9, there might just be 3. Okay, so the format, as I said, all the codes are alphanumeric. Every letter of the alphabet will be used except the letter U. What you know now as the V codes, so things like immunizations, well baby checkups, anything that's a V code, which is really circumstances, not necessarily illness or injury related, but V codes are other circumstantial codes. But what you know now as V's are morphing into Z codes. Your E codes for accident information, they are so much more specific now. There's 4 categories of those. V, W, X, and Y. So whatever you know now, and right now, I don't know what Aloha Care requires in the way of E code reporting, but typically it's how did the accident happen and where did it happen? So the patient fell out of a tree in their backyard at home. And that's all you need to know, because you're looking for third-party liability, someone other than responsibility for Aloha Care to pay the bill. So really that's all there is. Well, in ICD-10, fell out of the tree in their backyard at home. What were they doing in that tree? And and what was the activity involved? Was it part of a military army exercise that for some reason they were in a tree in their backyard? I don't know why it would be, but you can tell I'm making it up. But how it happened, where it happened, what were they doing when it happened, and what activity was going on, civilian, military, and so forth. This is going to be problematic on the front end in the clinics. They have a hard enough time right now figuring out that they fell out of a tree in their backyard and the date of that accident. That's going to be problematic. So we're trying to work with the facilities now and say, you don't have to wait till October to start doing this. You can start asking your patients now. Okay, so you hit your finger with the hammer while you were nailing a board while you were building a house. Were you working or were you volunteering? Were you getting paid for this? My favorite example is Tiger Woods on the golf course, gets hit in the head with a golf ball. Was he just putzing around and practicing on his own, or was he playing in a tournament for money? That's the kind of stuff they'll need to know in order to report these accurately. It could be that Aloha Care says, you know what, all we care about is the tree in their backyard. We don't care about the rest of the stuff. I mean, that may be what you decide to do. That you don't want activity codes and you don't want the, what were they doing? Was it work related and that sort of thing. Eventually, that will be really good because when you get that claim, you'll have all the information you need. You wouldn't have to request notes because they should be able to tell you the whole story with that claim form, but we're a ways away from that. As I said, the second through seventh characters are any combination of letters and numbers. So this is kind of problem number one for the front end in the clinics and the health centers, because that person who's doing their charge entry that is used to just doing 10 key, and sometimes they have to do an E code or a V code, but not to the extent of every single charge entry now that is alphanumeric. So it's going to slow them down to be alphanumeric, back and forth. It would really slow me down, I can tell you that much. So second through seventh are any combination. Here's problem number two. An O is not the same thing as a 0. We all know that. That's a no-brainer. Why the government decided to not use U and use O is a mystery to me because, for example, in ectopic pregnancy, the ICD-10 code is 000. So how many times do you think that's going to get messed up with somebody writing on a charge slip? 000 goes off to their biller. The biller goes, is this an O or a 0 or an O, or is it 000 or 000 or what is it? Going to go back to the provider for clarification. If they use an outside billing service, that stack of charge tags that has O's in there that don't look like zeros, that whole bunch, whatever's in there is going back to the provider for clarification. So slow down. You folks, you don't get, I don't think you get very many handwritten claims, but if you do, I don't know how you're going to figure that out unless that 0 is clearly a 0. So we're telling the offices, don't wait till October to start doing 0 with a line through it. Wherever you happen to be writing anything down, if you're filling out a lab request for DLS, if you're filling out an imaging request for one of the x-ray centers, just start practicing. An I looks like this and not like this because they're going to think it's a 1. So these are a lot of things that folks can start just being aware of it. Key punchers need to know that when that comes across their desk, they can't assume that an O, that just because it looks like that, it's an O or a 0. It needs to be clear. Now, luckily, most of the health centers and the physicians are using an electronic version of the requests, imaging studies and lab studies and even their e-prescribe and all that other stuff. They're using electronic versions and it should be clearer, but there's a lot of small practices out there that are still doing, especially crossover claims, or, there might be some confusion there.